Welcome to The Case of the Tan Fatigue, a diagnostic mystery where the obvious wasn't so obvious. Our story begins with a 34-year-old woman presenting to the clinic, appearing sun-kissed and faintly smiling, despite insisting she hasn't vacationed anywhere sunny. For 4 months, she's experienced fatigue, abdominal pain, and an unintentional 5-pound weight loss. Her blood pressure at triage was 94/60 millimeter of mercury, pulse 92 per minute, and she reported almost fainting in yoga. Initial lab results revealed a sodium level of 130 milliequivalent/L, potassium at 5.2 milliequivalent/L, normal creatinine, and glucose at 68 milligrams per deciliter, alongside mild anemia. She was otherwise healthy, took no medications, and denied vomiting, diarrhea, or diuretic use. This constellation of fatigue, hypotension, hyponatremia, and hyperkalemia strongly suggested an endocrine issue. Our first red herring emerged when the patient mentioned her mother had hypothyroidism, and she felt cold, sluggish, with dry skin. Clinicians quickly considered autoimmune thyroiditis, especially with TSH at 7.8 myo/L and free T4 at 0.8 ing/DL. However, primary hypothyroidism explains fatigue and weight gain, not weight loss. While it could cause hyponatremia, the hyperkalemia didn't fit. So, thyroid disease was a clue, but not the ultimate culprit. The second red herring pointed towards the kidneys, with the nephrology consult suggesting hyporeninemic hypoaldosteronism, or type 4 RTA. Although diabetes can cause this, our patient was not diabetic. Still, the labs fit: high potassium, low sodium, and mild acidosis with a bicarbonate of 18. Her urinalysis was normal, and renin and aldosterone levels were ordered. Type 4 RTA typically occurs in diabetics or CKD patients, neither of which applied to our patient, whose renal function was pristine. This was a tempting red herring, but the results of the renin and aldosterone tests would be crucial. The results returned. Plasma renin activity was high, but aldosterone was very low. If renin is shouting and aldosterone remains silent, the adrenals might just be the crime scene. During follow-up, she appeared noticeably bronzed, not from cosmetics, but with hyperpigmented palmar creases and buccal mucosa. This prompted a revisit to her earlier sun-kissed comment. Morning cortisol was 1.8 g/DL, and ACTH was 690 pg/ml. This diagnostic deduction of low cortisol and high ACTH pointed directly to primary adrenal failure. The pigmentation was due to ACTH-derived melanocortin activity, and the orthostatic drop in blood pressure was from a loss of mineralocorticoid tone. Her craving for salt, which she hadn't mentioned until now, was the final clue. A concentropin stimulation test showing no rise in cortisol confirmed the diagnosis of Addison disease. The final diagnosis was primary adrenal insufficiency, or Addison disease, caused by autoimmune adrenalitis, often associated with autoimmune thyroiditis, known as Schmidt's syndrome. Management included hydrocortisone replacement, fludrocortisone for mineralocorticoid deficiency, and patient education on sick day rules, an emergency steroid card, and a medic alert bracelet. In Addison's, the skin tells a secret, the electrolytes whisper the diagnosis, and the pituitary shouts in vain. When a patient looks healthy and tanned but feels exhausted and faint, think beyond the thyroid, think adrenal. Our first take-home message: don't stop at the first plausible diagnosis. Hypothyroidism and renal tubular acidosis can mimic pieces of Addison's puzzle. Second, electrolytes are detectives' clues. Hyponatremia, hyperkalemia, and hypotension should always raise suspicion for adrenal failure. Third, ACTH levels are the confessional. High ACTH with low cortisol strongly indicates a primary adrenal cause. Finally, remember autoimmune clusters. Addison's often coexists with autoimmune thyroid disease and type 1 diabetes. Thank you for joining us in unraveling the case of the tan fatigue. We hope this diagnostic journey proves valuable in your practice.